Our next speaker, Dr. Ho Jin, he did talk yesterday about bone, and he will join us again today. He is a full clinical professor in the Department of Radiology and Diagnostic Imaging at University of Alberta. He is full partner and medical imaging consultant in Edmonton. He practiced general nuclear medicine and diagnostic musculoskeletal radiology 50-50%. And because of this, he did acquire a regional reputation for such multimodality MSK cases, and consulted and asked for official second opinion from WBC, CMBA, and medical legal departments. He's going to speak about WBC Imaging. Dr. Jin Ho, the stage is yours.
Thank you very much. Can everyone hear me? Hello? I assume everyone can hear me okay?
Yes, we do.
Okay, perfect. Welcome everyone. Thank you for attending this session. The objective for the next 30 minutes was very simple. I was asked to show how we use white cell imaging at the University of Alberta Diagnostic Imaging Department. I want to emphasize a few things before I get started. I'm not going to have a discussion, full discussion about the general approach to inflammatory imaging. I think that's a broader discussion beyond my 30 minutes. I can certainly address that indirectly in a few slides. I should also inform you that in our department, we are an integrated department. All of my partners, including myself, who are nuclear medicine physicians, we are also diagnostic radiologists, so we do have direct access to the rest of diagnostic imaging. And I would say that within our within our nuclear medicine department itself, we don't just use white cell imaging. This is only one part of our approach to inflammatory infection imaging. We do employ other techniques that you will see presented following me. But for the next 30 minutes, I simply want to demonstrate how we use specifically white cell imaging. Okay, so here we go. Whoops, my slide doesn't seem to be responding. Pardon me for a second here. Okay, so pardon me for the glitch. Can everyone still see the screen?
Yes.
Okay, perfect. Here we go. So I have no disclosures. I promise I won't belabor the point. I simply want to point out that in an acute inflammatory infection environment, that environment is neutrophil rich. As we all know, it's full of activated neutrophils that continue to concentrate at the site of infection inflammation. Of course, there is a source of injury itself or infection. Of course, there are multiple chemoattractants, basically activated mediators. And as we all know, in modern inflammatory imaging, the goal of research, in the pursuit of research, multiple of these mediators have been labeled and tried for diagnostic purposes. But for today, just to point out that this environment is neutrophil rich and therefore ideal for white cell imaging, as opposed to, say, chronic inflammation infection, which is a completely different pathologic environment. It's lymphocyte, macrophage rich, activated macrophage, and of course there's fibroblasts. And it's not that there are no neutrophils, there are, it's just the concentration is lower, and therefore at least in theory better suited for other imaging modalities, which I won't address, such as gallium, bone gallium, FDG, which you will see presented following me. And of course, those of you who still have access to indium white cell, that particular environment, the indium white cell can work as well. So for the two tracers that you can use for white cell, we have much preferred, and we do exclusively use the technetium-HMPAO white cell. And I have to say, we have a long history with this, where our department is quite experienced. For as long as I've been in practice, which now approaches, in fact, which exceeds 30 years, we've always used technetium white cell. Essentially, we've used it ever since the tracer was declared available and documented in literature. We will add the addition of a marrow scan if we're dealing with a case that has axial skeleton within axial skeleton, or if we're dealing with neuropathic arthropathy, or of course, if there is prosthetic hardware, as literature recommended. In our protocol, we will do a dynamic study, that is to say 1 hour dynamic imaging if there's any concern for potential bowel pathology, because we're looking for the early, the abnormal, of course, early appearance of white cell within 1 hour. But we will routinely perform 4 and 24-hour imaging, plus or minus SPECT CT at various time points as the case dictates. And so if we perform a 1 hour dynamic imaging study, we're basically looking to ensure that we don't see any early appearance of bowel activity, which for technetium white cell is pathologic. The normal technetium HMPO white cell distribution at 4 hours is shown here with basically that description. This is the typical appearance. You don't see bowel activity here, but you certainly can see some bowel activity as a physiologic, on a physiologic basis. So between indium and technetium, we much prefer the technetium. We prefer it for several reasons. You know, the technetium is a far more pleasant nuclide for imaging. This is a much more photon flux study, much better conducive to modern day SPECT CT imaging, which we strongly favor. But of course, there's no free lunch. We pay a price for that. And the price we pay is that we can't image beyond 24 hours, which has certain theoretical disadvantages, which I'm going to address shortly. So this is our diagnostic, this is the basis of our diagnostic paradigm on how we interpret white cell imaging. And labeled white cells in the bloodstream disappear from the blood pool very quickly. The axis here is an hour. So, you know, from 0 to 24 hours, blood pool activity diminishes very quickly. Marrow activity rapidly increases and stabilizes. And this is true infection. In theory, a true infectious inflammatory focus is characterized by a continued concentration of your physiologic activated white cell or your reintroduced labeled white cell, right? There's no reason for the white cells to stop coming just because you turn your camera off. This is what should be happening, and this is the basis by which we will call positive for infection. And here is what in theory happens in a chronic infectious setting. You do have some infiltrate of activated neutrophils. It's just a much lower concentration. So that is to say the amplitude of that curve is much lower. So therefore, unfortunately, to be able to see enough activity as target beyond background, you need to image far beyond 24 hours. You need to get into the several days. And this is where the longer lived nuclides such as gallium and of course indium white cell would have the advantage. So that is the price we pay. This is not necessarily the best, and in fact it is not an ideal tracer for say chronic infection. And of course subacute would be somewhere in between. Now this is important. If white cell activity appears to show within the first few hours but rapidly declines, we will consider in theory that that is not infection. That is not a pattern compatible with true active infection, and we will report accordingly. So for example, if a focus, this is marrow 3 hour 24 white cell, if a focus appears and persists, and we will call that infected. And oh, by the way, I forgot to mention one thing, excuse me, apologies. I just want to address one more issue. I don't think it's an issue, but just to say, the authors of this paper, for example, who promotes this curve, they will take this to an absolute in practice. And that is to say, with technetium, we are somewhat handicapped by the half-life of our nuclide, right, the 6 hours. So in Dr. Signor's department and in some departments in Europe, they will actually decay correct their planar images. So the requirement for this curve is absolute. we don't do that. I don't think it's absolutely necessary. We will compensate to get at this curve. We will compensate in our image interpretation accordingly. So we don't decay correct our delayed images. So again, if a focus appears and it's not clearly and it's not marrow, if a focus appears and it persists, that is infected, as opposed to a focus, for example, here that appears early but it fades, that is considered non-infectious. And in fact, this case I can tell you is absolute. This just happens to be a patient with gout who is known to have a large tophus in the elbow, and I'm 100% sure this is not even part of the clinical test. It just happened to be in the field of view, and I thought that was a very nice looking picture, and I asked the technician to give me some delayed images. So infected, non-infected. Another example with gout, there's concern regarding that swollen fourth toe, and you can see there is some early white cell appearance that doesn't persist. In fact, completely normalizes at 24 hours. So this is not infectious, okay? As opposed to, this is another example, another patient with gout, more advanced gout. You can see the erosive / destructive change. You can see very advanced gout. And he also happens to have an ulcer. So this case is ideal because it gives you a nice reference right away. So in and of itself, advanced gout doesn't necessarily have to show significant infectious inflammatory activity. By contrast, this patient's deep ulcer certainly does. And so very nice demonstration, non-infectious and infectious. And of course, marrow is very important for several reasons, as this example shows. If you have prosthesis, if you have foreign body, basically prosthesis, it's been well documented in the literature that you can possibly form anomalous marrow. And of course, we know that happens with neuropathic arthropathy as well. And so if you have anomalous marrow, you need to know that, and therefore you have to have a marrow map so that you don't incorrectly call white cell uptake infection. By contrast, an area of white cell accumulation that does not have marrow, you're free to go ahead and call that infectious. And this happens to be adjacent to a large ulcer. Delayed imaging is important for other reasons as well. So marrow for 3 hour, 24 hours. The white cell distribution early on at 3 hours may differ and may be a little more extensive at 24. Basically, it will evolve. And so you need to know what is the actual distribution at 24 hours. You need to know that it persisted to confidently call infection. And so whereas at 3 hours, perhaps you might be comfortable saying that this is not osteomyelitis, it's relatively superficial. I don't think, I'm not at all convinced that there's bone involvement. You might think differently at 24 hours where there is a far greater depth of involvement. I would not be comfortable letting this one go as negative for osteomyelitis, for example. And of course, if you're dealing with a small part such as a foot, which, you know, unfortunately for us is bread and butter, the registration clearly matters. So a focus of infection that appears to be arising from bone, you need to absolutely make sure that there is no registration error, which I didn't initially. And so luckily for me, once I realized it, luckily for me, I was able to get a second acquisition at 24 hours, correctly performed, showing that in fact, no, this is not arising from bone. That previous was a registration error. So planar imaging, so prior to SPECT-CT, of course, remember technetium HMPAO white cells have been available for close to 3 decades, for as long as I've practiced. And indium oxide white cells even longer, but our tracers well precedes SPECT-CT technology. So back in the planar days, the planar image certainly has diagnostic value, no question. You can do a whole body sweep. You can see that, for example, in this patient with burns, the full extent of white cell distribution. For example, this patient has necrotizing fasciitis. This is intuitive, an intuitive distribution. This patient has pseudomembranous colitis and the colonic distribution at 24 hours. Of course, in this patient, we would have done a 1 hour dynamic acquisition. to ensure that this does appear early at the 1 hour mark, but you can clearly see the distribution of colitis. So planar images certainly have value, but even for small parts preceding SPECT-CT, when we didn't really have a choice, you do what you can. Bone, marrow, white cell, we are, just intuitively, we are reasonably confident in saying that has to be within bone. It's way too deep to be just superficial. This is a prosthetic infection case. Recently inserted total hip arthroplasty, marrow, 3-hour white cell, 24-hour white cell, and clearly there is active infection. And this is just a planar set of images, but just based on gross anatomy alone, we were comfortable to say that this is incisional infection because it does appear superficial to bone. So we could reassure the clinician that it's an infection only of the incision and not of their prosthesis. But truly, in modern times, you're going to use SPECT-CT. We much prefer to have SPECT-CT. You want to have that fine spatial resolution. You want to have that full dynamic range of spatial resolution, because most of the time, the question is not whether there is infection. The clinical question is the depth of infection and the extent of involvement. And particularly, right, I'm sure you are quite familiar with this. All the clinicians always want to know osteomyelitis or no osteomyelitis, because clearly that dictates the length of antibiotic therapy. So we much prefer to have SPECT-CT for that full dynamic spatial range. So superficial with no bone involvement, relatively deep. Okay, this is getting close. I'm going to have to start considering maybe some superficial involvement, and clearly deep, where you have extension of infection from the ulcer to deep soft tissue right into bone territory, because the bone contour I could show you on the CT component is this. And some examples of just outright deep osteomyelitis in a diabetic foot ulcer. This one is very deep. This is the bone contour. Perhaps there might be some disagreement, but I would call that infected. It appears to cross the bone contour. I will call that infected. This one you could probably call infected on radiographs alone. There's some destruction of the proximal phalangeal head, but there is nothing like a nuclear medicine bone scan with 24-hour imaging to show the full distribution of white cell, which in this case, yes, absolutely involves the proximal phalangeal head and does as well involve the IP joint, including its recess. And this one beautifully demonstrates the extension from this ulcer, which is the source of the infection, to deep soft tissue right into bone territory. You can see here on CT the bone contour, and so clearly there is osteomyelitis involvement. That's an easy read. Now, this patient clearly has advanced, terrible diabetic neuroarthropathy with deep soft tissue infection, gas adjacent to bone, and even intraosseous bone. And of course, here's the neuroarthropathy, just chronic dorsal dislocation, subluxation of that MTP, also with deep soft tissue gas. This one, I dare say is positive already just on conventional CT, but you have to realize this CT was generated by us, the SPECT-CT component of our white cell study. This is not a separate CT ordered in the regular department. And so the white cell distribution clearly demonstrates infection throughout metatarsal head, the deep soft tissue, the sublux joint, and on a coronal plane, you can see the extension of infection to the dorsal deep soft tissue, basically everywhere where there is gas, and possibly starting to invade that fifth metatarsal. The anatomy from SPECT-CT is often spectacular. This patient, for example, from the ulcer has gone to deep soft tissue and has infected his flexor hallucis longus tendon there. This is exactly the distribution of flexor hallucis longus tendon. Here's just an MRI anatomy diagram just for anatomic reference. This patient infected not only his flexor hallucis longus tendon, and I didn't recognize this initially. I was quite puzzled until I had to think about it. He not only infected his flexor hallucis longus tendon, but he also infected the fine plantar plate complex with its sesamoid metatarsal and sesamoid phalangeal ligaments. That's what these are, the fine ligaments. So that's not osteomyelitis per se, but it is very, very deep soft tissue infection. And this patient in a bar fight sustained a human laceration injury to the extensor surface over the metacarpal over the MCP, the second MCP, infected the second MCP, but of course then seeded his extensor tendon and the infection went down the tendon sheath. And you can see this on SPECT CT. Now this is into the forearm, the white cell distribution. But I apologize to Dr. McIntosh, who I know is sitting in the audience. This is his case. So sorry, Chris, I should have put your name down. So thank you for this case. And this patient infected his rectus femoris, tensor fasciae latae compartment of the thigh. And so you can see it's quite extensive. And there is as well concurrent septic arthritis of the knee, seen here on SPECT CT. There happens to be some intraosseous gas. Prosthetic infection easily demonstrated with white cell marrow. So it is not at all difficult to tell the clinician that in addition to an incisional infection that they already know of, you unfortunately infected deep down to the prosthesis. All this meadow is going to have to come out. It's not difficult to say of the bilateral calcaneal fixation, this one's infected, this one is not infected. That's the beauty of white cell with technetium white cell. White cell marrow, white cell marrow, you can see the incongruence, you can see the zone of infection, which includes infection of the wires, the sternal wires. And of course, within marrow space, it's important to compare with the marrow distribution so you can see this zone of incongruence. And of course, then you can go ahead and use SPECT CT for anatomic specificity. So I know there's active infection, and SPECT CT tells me it is exactly the distribution of the SI joint. The full distribution of SI joint has abnormal white cell, which includes, by the way, its recess. It has an anterior recess that presumably is distended with pus from the infection. And this fever of unknown origin case, sorry, not fever, but this febrile illness case, acute, shows intense activity in the chest, which SPECT CT localizes to the aortic arch. And of course, we know from the literature, in particular, if you have a very discrete focal site of active inflammation by whatever tracer you use, that correlates well with true septic vasculitis, as opposed to, say, inflammatory. So septic aortitis. Just to show you, and I promise I'm not trying to steal the thunder of my successors, but just to show you what we will not advocate white cells for. An old case, a patient with discitis vertebral osteomyelitis, as concordant with literature descriptions, white cell appearance is typically that of photopenia. And so you are, this is an old case, obviously. In modern times, you would be using MRI or FDG PET. But it's just, a historical case showing how in the axial skeleton, particularly with spine, the white cell appearance is unfortunately photopenia. And I know there are reports of it actually being hot, which also means you can actually have negative. So we do not advocate white cell imaging for the spine. You're better off using other tracer modalities, which I know will be discussed following my presentation. So I'm going to address this. I'm sure I get asked this question a lot. Half the time I am on duty in nuclear medicine, the nuclear medicine department. The other half of the time I am on duty in musculoskeletal imaging, particularly MRI. And so I see infection from multiple modalities, half the time in MRI, half the time within nuclear medicine. I often get asked the question, what is the more accurate? And perhaps my best answer to you would be to show you this case. Diabetic foot, that is our bread and butter, the bulk of, overwhelming majority of our white cell cases. So I was on duty, not in nuclear medicine, but I was on duty in MRI, and musculoskeletal fellow sitting beside me, reporting cases for the day. And we were asked to demonstrate the distribution of a patient with known soft tissue infection with a probable ulcer, and we are asked to document the full extent of the ulcer for pre-surgical planning. So it's not difficult to see the distribution of abscess on MRI. Here it is, beautifully outlined by contrast, and also a little bit of gas within the abscess. And so, we reported this, and the report is complete and nearly signed off. In fact, I think it was signed off. And I was trying to impress my musculoskeletal fellow that in nuclear medicine department, we have the means to demonstrate the same pathology. Because I noticed that white cell study, a white cell scan preceded this MRI by like a day or two. So I proceeded to bring my MSK fellow with me to our nuclear medicine department, introduce him to our department, and ask my colleague on duty at the time, Dr. Ling, to pull out the case and show him. And so here it is, you know, easy concordance, beautiful concordance. And then I noticed this. And then, you know, we looked at each other and we thought, oh, wait a minute, what's this? Did we miss something? So we quickly went back, said thank you very much, went back to the department, pulled out the MRI, and sure enough, you know, it's not that the MRI didn't show this. We basically neglected this. So presumably that is infected as well. It just so happens that's not yet abscess, it's phlegmon. So, you know, I think the real answer is, to me, functionally, seeing infections with both modalities, they are equally accurate, and the sensitivity is probably equal on both sides, as long as it's properly executed on both sides and properly interpreted. I should inform you, it's a lot easier to diagnose osteomyelitis on a white cell scan than it is on MRI. It is, you know, particularly the diabetic foot with neuropathic arthropathy, it is a nightmare. You just have absolute, particularly in the advanced neuropathic arthropathy cases, where we have extensive destruction, extensive bone marrow edema. It can be very, very difficult to sift out infection from just pure sterile neuropathic change. Now, again, it can be done, and I do insist, when properly executed with contrast and properly imaged with proper imaging criteria, I think it's equally accurate. It just needs to be done correctly. And so I think they are equivalent. And of course, there occasionally comes a question of, well, then what is the indication? Clearly, this MRI study was ordered by the surgeon because he wanted to know the abscess distribution. And of course, we can all accept that, you know, it's a lot easier to accurately define the extent and the volume of abscess using a pure anatomic modality such as MRI than white cell, even though the two will show you the true extent of infection. And of course, both modalities here clearly demonstrate absence of osteomyelitis, which is what, right, which is what the infectious diseases physicians want to know. So with that, I'm done. Thank you very much for your attention. These are my affiliations.